The DaVinci Hour is a new podcast interview series with a variety of individuals across the field of medicine, and it's meant to provide you an inside look into their experiences and some thoughtful advice on how to navigate your journey towards your dream career.
All right, everybody, welcome back to the second episode of the DaVinci Hour, brought to you by DaVinci Academy. I'm Dr. Maxwell Cooper, your host again, and I'm joined this time by Dr. Nikita Ashcherkin, who is an internal medicine resident at Mayo Clinic in Arizona. And we met at the University of Toledo College of Medicine, where we were medical students doing the medical student grind. And now we're doing the intern year grind. So in this episode, we're going to kind of give you some tips and tricks on how to adjust from that make that big jump from medical school to intern year. And we just want to say congrats to everyone who matched out there, and hopefully it was what you wanted. If not, I guess you're stuck, but that's all right. At the end of the day, you'll be a licensed physician. So we'll help you make that jump. So Nikita, how you doing, man? What rotation you on? How are you doing?
Good, man. Thanks for having me. I was just thinking it's been it's crazy. It's been 5 years now since that first year anatomy class downstairs at Toledo.
It's crazy, man.
But yeah, it's good. I'm on ICU month right now. So at my program, we do 1 month of ICU first year. So and we can talk a little bit about different programs later on about the XY schedule and all that stuff. But yeah, so almost done with that month of ICU, going on to outpatient next month.
Very nice. Yeah, so I actually just finished, as we were talking before we started recording, I just finished my month of MICU. So I feel for you, man. It was a tough rotation, but it's a lot of good medicine, a lot of good physiology. And it makes you really kind of critically think about what's like physiologically going on. I felt like, I don't know if you've had that experience as well.
Yeah, I feel like the ICU attendings have to know basically physiology to the point of almost all the subspecialties. You know, cardiology, you have to basically, I mean, they manage most of it on all of it really on their own. Nephrology, they do dialysis on their own. They can, do their own orders for dialysis. So it's really the peak of physiology, I feel like, that you do have to know for especially like all the subsystem, for subspecialties, you do understand your organ system probably the most, but they really have to be on edge kind of all the time.
Absolutely. Yeah. I mean, I felt like, you would consult people in the ICU and the MICU, and you consult cardiology or nephro or, whoever. And I felt like there were more suggestions than necessarily like strict recommendations. Like I felt like on the floor, like usually, you follow what cardiology says, or you follow what, nephrology says. And I think they still follow it or take it into consideration. But I felt like as you said, the ICU doctors, they also consider like the whole picture as well. And like, does this, one recommendation necessarily fit with what we're trying to do overall with the patient? I don't know. That was just my experience. I felt like,
yeah. And I guess at that point too, if you're consulting like a subspecialty service on the floor, patients probably are not that sick, right. But if they're in ICU, I mean, you have to do something, so yeah, maybe that plays a role as well.
Yeah, I agree. That's awesome. So I don't know. I'm glad I didn't start with ICU. I can tell you that I had done 4 months of wards before ICU, and I still felt like it was a pretty big adjustment. Like, even though I'm like in the second half of my intern year, I don't know, that first week was tough, man. Like it was still like all the drips, and those of you, who are still students and aren't familiar, like drips, just kind of, continuous IV infusions running, like sedation, pressors to maintain patients' blood pressure, paralytic medications, just, sometimes you're running insulin drips, for people with high sugars and things like that. And so these are all types of things, those of your students that aren't typically done on the regular medicine floors. And so I guess, you don't see any of that stuff on the medicine floors, and then obviously the ventilators and all those types of things. So I don't know, it was kind of a steep learning curve at first for me. I don't know about you.
Yeah, I even, I did a month of ICU at Toledo, and as a fourth year, I think they were just transitioning between like ProMedica and University of Toledo, but so there were no residents on the service, so it was just a fellow. But I don't know, even doing 1 month in med school, I mean, I guess it depends probably where you are and how much autonomy you get as a med student, but even after that experience, I was still like, it was hard to learn all the drips, sedation, especially, like which sedation do you use? How much can you give? And the vents, I learned about vents so many times now. I learned about vents yesterday again. And it's always like, there's always something new to learn about them. And I think at that point, you really just have to think about how you change the settings on each patient, even if you're not doing it to really make it stick. But yeah, all that stuff after even 2 weeks, you still have to constantly relearn all the time. So definitely a challenging rotation. I'm glad I didn't start on it. But I think it makes it less scary going back to like the floor because, I guess you kind of know when it's time for patients to go to the ICU, or again, you don't have to do any of those, pressors and sedations on the floor, which is a little less nerve wracking.
Yeah, no, I definitely agree. I think the biggest thing I tried to get out of it was like like you said, like when a patient is really actually sick and needs, higher level care, and when it's, okay to kind of press forward on the floor.
Right.
And then from a radiology perspective, also like when they're, from a procedure standpoint, are they too sick to come down to the IR suite and do a procedure? Is it still okay? And then obviously from an imaging perspective, there's a lot of it, as I'm sure you've ordered plenty of imaging on your patients. It's also interesting as well to gain experience doing that. Cleared a lot of lines.
Yeah, and I think, I don't know, I remember at Toledo, there were a lot of central lines. I don't remember too many pick lines being placed, but for example, at our place, there's a lot of pick lines. Pick team comes and does them pretty quickly.
Yeah.
But it's definitely fun as a resident to get to do like a central line and a femoral line. So those are a good experience to get an ICU. Hopefully, don't think we ever have to do that on the floor, but hopefully not.
Yeah, things are going kind of dicey if that's what's going on.
Yeah.
So I guess in the heart of like making that transition, I guess maybe I'll just start out by asking you some questions.
Yeah. Don't steer from the questions because then I'll be unprepared.
No, you're good. You're good. And we'll kind of stick with these and then we can kind of expand on them as well. So I guess the first question I have, a lot of students, they just matched, they're in that fourth year, kind of bliss area between like kind of finishing up their last rotation. They're getting ready for July. Maybe some of them are just hanging out and having a good time, and there's nothing wrong with that either. But I guess I feel like a lot of people ask, like, how did you spend your time between the match and starting intern year? Like, did you study a lot? Did you just kind of hang out? Did you just kind of get ready to start? I mean, I don't know. What was your process?
Yeah, I think it's, it depends on, what stage in life you're at or what you're doing in that time. Because a lot of people maybe are doing research and they're trying to finish up projects. So definitely probably a good time to do that just to finish things up and so you can be free intern year. But I personally, I was like, I was thinking I was going to study, and then I was like, I'll read all of step 3 like material and just review it real quick. And that didn't end up happening. So again, this year was strange, and our year was strange as well, especially at the end because all the trips were canceled. People were going to go on vacations. But my fiance and I got very lucky because, we went to Costa Rica right before kind of everything started happening in the States.
Oh, that's right. I remember you guys snuck that in right
yeah,
before it all happened.
While we were in Costa Rica, like that one, I can't remember if that was the first case in like Washington or something like that we heard about, but so we were able to squeeze our trip in, and that didn't get canceled. So went there for a month, and I think if that's an option to do a trip or just relax, take time off before intern year, I honestly think that's the best route. The time between college and med school, we did a very long road trip, like a 40-day road trip driving from Ohio to West Coast and just camped at all the national parks. And I think, for people who go from school to school, residency is basically school. We have these little time frames between transitioning from college to med school, from med school to residency. And those are really the only times we get to take those long vacations. I think it's just best to take that opportunity to do those things that you normally wouldn't get to do.
Yeah, I agree with you 100%. I mean, I think last year was a weird year. I think it's a little bit better this year. But yeah, if you can safely take a trip, I think that's great. I mean, I think you hear this and you just don't have the time like to do stuff like that. Like, when you're on a lot of these rotations, you have one day off a week, if that sometimes. And then I don't know what your vacation schedule is like, but at least this year and for my transitional year internship was we had 3 weeks of vacation, like kind of just randomly spread out throughout the year. And we had 5 days at the holidays, and that's it. Like that's all the time we had off this year. So for me, it was, I'm taking a trip next week when I'm off, but otherwise it's been a lot of just kind of doing the grind.
Yeah, and yeah, so our schedule is similar. We have 3 weeks of vacation. You can they're not pre-assigned, but again, you can take them during certain outpatient months because we do the X plus Y schedule. But you also have, you have responsibilities during this year too. Step 3, I don't know, depends on what you're trying to do. You probably want to take some time to study for that. So let's say that's a week of your vacation right there. Then you get, holidays off, so you'll get to travel then. And then, so that cuts down to 2 weeks of time where you get to take time off, and you can't take that consecutively, or,
Right.
So it's going to limit your options. And if you have a partner in residency, like my fiance doing OBGYN, her vacation doesn't always line up with mine. So,
That's right. Yeah.
so
Yeah.
you might take a week off, but you'll probably just hang out at home or something along those lines. And what was I going to say? I'm blanking on it, but again, like this is what I was going to say. So it depends on where you matched. Honestly, as soon as we found out where we matched, we flew here, found a place to live, and just moved. And we had those 3 months to kind of paint the house, do some, buy furniture, furnish our apartment, also like get used to the city. I think that, it depends on where you're going. Like if you're going to a cold place, I mean, I guess we match in the summer, so it should be warm for the most part.
Yeah.
And if it's a place you want to live, it can sort of be like a vacation right before you start. But I think getting used to driving around town, finding places you like to eat, that could also be another way to kind of spend that time.
Yeah, definitely. I think getting acclimated. I mean, you and I, we both grew up in Ohio, went to school in Ohio, and then we kind of both, even though we're in different spots, we went to these very different kind of regions. You in the Southwest, me in the Southeast here in Atlanta, Georgia at Emory, and just kind of getting used to like, I mean, back where I'm from, I could still draw you a map of all the roads and stuff. Like I know exactly where to go and everything because I just spent so much time there. But now, like, still got to use the GPS. Even at this point, embarrassingly enough, not the hospital. I can do that in my sleep, but but other places, I still got to use the GPS and all that. And I think just getting, like you said, getting acclimated, figuring out where the good food spots are, and just kind of doing the activities you like to do is a good way to spend it. I don't know. I feel like some people may try to study. I remember I thought I was going to, and I just didn't study that much, honestly. Like I just didn't have it in me. Like I don't know. There's too much grind leading up to the match, and then I don't know. I just like did stuff that I wanted to do. Like even though we were kind of confined in quarantine, like I don't know. I just kind of relaxed and took my time.
And I think at this point, just studying the material is kind of hard to just because you don't have, if you're just starting, if you haven't started residency yet, you're trying to relearn all this stuff. In residency, you see a case and you remember things based on that. You had a hyponatremia patient, you'll go home, study it, and you can sort of make it stick just by remembering that patient. And if you're just, studying without anything to kind of make it stick just for those 3 months, I don't know. I don't know if it's not worth it because you're going to be studying all this whole entire year and next year and the year after.
Yeah.
So
it's lifelong learning. Yeah.
I think it's important to take a break. And
I feel like you could study, like you could say, oh, I'm gonna learn heart failure and I'm gonna learn everything there is about heart failure. And you may know the physiology really well, but you could get in, let's say you start on internal medicine wards the first month, you could have like all COPD exacerbations. You could have, and like, you could not really, you could maybe see one case of heart failure. It's so variable. Like I've had weeks where I've had 4 patients with heart failure, and then I have, other weeks where I don't have any. And so it's just like, it's just, and I feel like you said, it's from the cases. Like when you see enough cases of heart failure or COPD or, DKA, that's where you really learn it, I think. Versus like, because there's a lot of the stuff that textbooks don't tell you, like, that you just kind of learn on the job from, just getting thrown in there.
and honestly, the first few months are just kind of learning the system, learning how to put in orders, how to be efficient.
Yeah.
And, you can't learn that stuff. So just enjoy life just for those 3 months. And not that to say that I feel like, you still get some time off. You still get time to relax during residency. Not to say that it's over by then, but I think you still have things that you feel like you're responsible for. Maybe like following up outpatient stuff, and even though during the vacations and weekends off, there's still things that are on your mind. So those 3 months before you start residency, you really you don't have anything to worry about. So just relax.
Absolutely. So what was your first rotation, and kind of like what were some of the challenges you faced like in those first few weeks when you're not I'm Nikita the intern, not the medical student anymore.
Yeah. So yeah, my first month was medicine wards, and our structure, we have one senior, and they typically pick a PGY3 to be the senior for the service that first month, because probably they know the most, they're of most help, and PGYs2 would just be becoming seniors that first month. So
right, yeah.
it's good to have someone experienced. And then we have 2 interns on the team, and so I think the hardest part was getting used to the workflow. So in the morning, getting a system down, when you go into Epic, it's nice, I guess different EMRs use different systems, but it's nice to arrange things with the flow that you're going to use. So like vital signs, tele, labs, and just figuring that stuff out so you don't miss or forget things. And that takes a long time. I'd say that still things happen and you still forget to check on things, but once you have a system down, you probably miss less things. Definitely. And then putting in consults. I think that was the biggest thing that I learned like the first week, is you have to consult right away in the morning. Because I remember we started rounds, and then my attending was like, "Hey, okay, so did you talk to GI or hematology?" And I was like, "Oh no, I put in the consult, I just haven't called them yet." He's like, "Oh," and I was like, "Oh no, you got to call them right away, because otherwise we don't have the information." I was like, "Oh, that makes sense."
Yeah.
I will. But those things you learn quick, just after making that one error, and not necessarily an error, but you didn't know, and after that day it's fine, because to call them in the morning.
Right.
And then efficiency, I think, was the biggest issue for me. So I'm a slow typer, so I moved to the States from Russia, didn't type on the computer there until I was 12. Here, didn't really type that much up until like middle school, high school. So never really took the time. I still type with, I can do the multiple fingers with the left hand, but I still do the one finger with my right hand. So probably shouldn't reveal that to the public, but
it's all good, man.
But it took me a while to type my notes, and you're also figuring out how to structure them. The assessment plan, figuring out each problem and how you're addressing it. So typing that out took forever, and the first couple of weeks I was there until well past my shift, just trying to finish up my notes.
Yeah.
And then a few weeks, actually it probably wasn't until 3 weeks in, or even maybe my second medicine month, that I started using the voice feature.
Oh, like the dictaphone?
Yeah, I don't think it's Dragon. I forget what the system that we use is called.
That's nice you guys have those. I think we have them in radiology, but we don't have them in the medicine floor.
Oh yeah, I don't touch the keyboard now. Like sometimes I guess I still type my notes if we're like by a patient room and working, but that just saves so much time, because for me, maybe some people can type faster than they talk, but not me, and that saved me hours of work.
Yeah.
So I think the first month I was still slow. The first month I was out late most of the times. My senior was of great help, like discharge summaries. Like those are hard. As an intern, you're writing out the whole entire story. Like they arrived in the ED, these were their vital signs. They gave them this, and then later on you realize like the outpatient doctor has to read that discharge summary. They do not want to see every single vital sign every single day.
No, they want the big picture. Yeah.
Right. So I think those like system-based things were just the things that were hardest for me to learn. Yeah. How about you? Was that something that you struggled with in the beginning, or was it other stuff?
Yeah, I would say, especially I started in the emergency room, which is and I was only there for a month and I'll never go back there. Which I was glad I did that month, but I have a lot of respect for what the ED doctors do, but it's not for me. It's I did it at Grady Memorial Hospital here in Atlanta, which is the big county hospital, as you know.
Yeah.
So it's the Wild West. You see everything and anything that comes through that door. That was an adjustment in of itself. But yeah, I think when I started medicine wards right after that, I'll never forget the first day. I was there till like 11 o'clock. It was an admitting day. I took over I think 5 or 6 patients. And then we got 3 new admissions. And yeah, I mean, I hadn't done a medicine rotation in like over a year. And so like, I was just, I mean, my 4th year, I was kind of a clown. Like I did a lot of pathology and like just kind of worked on research. And I didn't do a lot of, I did some clinical stuff, but I kind of took it easy too, and just worked on other endeavors like DaVinci Academy and research and things like that. But so yeah, I was very rusty when it came to internal medicine and like how the notes are structured and everything. I think I wasn't alone in that. You're not alone in that from talking to other colleagues here at Emory, and I'm sure talking to colleagues there at Mayo. I mean, I think it's very common that first month, like everyone's notes are longer than they need to be. like, uh, everyone, I think I almost when I look back on engineer, I didn't start out with this mindset, but when I look back, I kind of developed this mindset like a few months in I almost looked at intern year in phases, and I don't know, maybe this works for people, maybe it doesn't, but for me, I think the biggest thing is like, you're there to get a job done. And so that's kind of how I looked at the first phase, was like getting things done, like getting orders in, like getting consults called, like you talked about, things like getting the tasks done for the day. Because at the end of the day, like I've always had the mindset, like if you got the work done in a reasonable amount of time, it's kind of hard for them to give you a lot of grief. You know what I mean? Like maybe you didn't know these guidelines for something, or you didn't know how to dose this person's antibiotics or whatever. But at least if you didn't delay patient care, or delay things. I think, at least from my perspective, I think that's kind of the biggest thing at the end of the day. So like learning the workflow, like you said, I think that was tough at first, like, because I didn't know, exactly what you said, like, oh, you got to call consults like right in the morning, because otherwise, because what you don't realize is like when you call them, then they put it on their list and then they know to see them. Like if you don't call them till 3 o'clock, they may have rounded already. Like, and then you kind of, maybe they'll still go see them, but they'll be kind of annoyed. I've definitely learned that the hard way. And so, yeah, so I looked at it like the first phase was like getting a system down, like how you do your pre-charting, how you go through the chart, how you get your vitals down. And I think that's, whether you're in medicine or surgery or OB-GYN or anything, I mean, everybody's got to like look through their patient's chart in the morning. So I think kind of like how you organize that information. And I have really bad handwriting. So like, it's been kind of like, that was actually kind of a struggle for me, was like figuring out like the best way to organize that. And I use these, like Epic has these, patient handoffs that you can print out, and it has like a lot of the vitals, a lot of the stuff you would otherwise write down. And so thankfully I have those, and then I kind of just write the plan now. But it took me a while to like come up with that system. Like at first I was like presenting off the note, and it was like, you may think, oh, that makes sense, like you just present off the note, but when you print off the note, at least for me, it's like there's too much there. Like there's all this info, there's like your whole like explanation for each problem, and it's just, I don't know, I felt like it was hard to find things. And so I don't really do that anymore. I think it's too hard. The only exception is I did do that in the ICU, because there's just the ICU, like there's just too much, like you needed, I felt like, some kind of guide. But anyways, yeah, so then I looked at it like that, and then kind of the next system was like really knowing what's going on with your patient, like, because I feel like you're so caught up in like getting the work done that sometimes you can get lost in like, what's going on, like what is like, obviously you'll know what the patient's there for, but like the intricacies of like what we're doing, like, in their disease process and like, their treatment. So that was like the first like month or two, I try to just focus on like my system, getting the work done. And then kind of like after that, I kind of really tried to really know my patient well. So like when I called a consult, like I could confidently tell them like what was going on with the patient, and why we were doing certain, treatments, and why we were ordering certain labs and things like that, why we were consulting them and things like that. Because even calling consults is, like I'll try to teach the med students here, like you always have a question, you always want to give them like a brief synopsis, and like you want to tailor it to like what that service cares about. Like when you call cardiology, they're not going to care about, oh, that they had a colonoscopy 5 years ago. GI would care about that. but cardiology doesn't care, so like things like that. So yeah, like, and then like the last phase has been like that I'm kind of in now is just like building my medical knowledge. Cause I feel like if you try to do all three of those in your first month of intern year, it's just like too hard. I don't know. That's my experience. Cause you almost need to get being a resident down first before you can really do anything. It's almost like you got to crawl before you can walk. I feel like.
Yeah. That's what most of the seniors kind of early on told me. Like first year, you're just trying to learn how to be an intern.
Yeah.
And you pick, medical knowledge comes up. You talk about stuff on rounds. People are teaching you. You'll go home. You'll want to look up some stuff. Just to know what to do the next day.
Right.
And that just naturally kind of happens. But for the consults thing, another one was you always want to, like as an intern, you call, you're like, hey, I have a new consult for you guys, 58-year-old, whatever, blah, blah. And then you always just want to ask like, or mention like why you're calling. Like the cardiology, you don't start telling the whole story until the end because they don't know what they're listening for.
Right.
And sometimes if we're really busy, you still get caught up. We forget to do that. But I think makes life easier because sometimes they're like, oh, AFib. Okay. Then they'll like ask even the specific question. It'll kind of guide your presentation too.
Yeah, definitely.
But that was a good lesson.
Yeah.
Well.
I feel for the fellows who have to field those calls in the beginning months. And then like, so yeah, that's kind of like how I've looked at it. I don't know if that's the right way, but I feel like it's helped. I don't know, just kind of, because it's a progress. Like you're going to struggle. You're going to feel like you suck, especially in those first few days. I still have days where I feel like I suck. Like, I mean, it's just hard. And there's a reason why like internal medicine is 3 years. There's a reason why radiology is 5 years. There's a reason why surgery is 6, 7, 8 years. I mean, this is really hard and it takes, a long time to get there. And so I remember, I'll never forget the first attending I had on wards. He's like to the interns, he's like, you guys may feel like you're struggling, but he's like, don't worry. He's like, you'll get there. And I always think about that. Like, he's like, you'll get there, one way or the other, you'll get there. And so I think you just got to remember that. I think a lot of interns get really frustrated that, they don't know, they feel like they don't know, like, especially that first month, they don't know what's going on with their patient. They don't know why we're, giving a certain diuretic regimen for someone in heart failure. They don't know, and there's nothing wrong with that. I mean, you're not someone with reasonable expectations shouldn't expect you to know if you knew everything, you wouldn't need to do residency.
Right.
So I think knowing, I think it's, it's a process. I think being patient with yourself and knowing it's a process, I think is my biggest advice to people starting out.
Yeah, no, I think that's fair. And just not being too hard on yourself.
Exactly.
You're there to learn. It's still all new, especially when you go to your service too. You get used to medicine, you do 3 months of medicine, you're like, oh, okay, I'm kind of understanding the workflow, everything works. Yeah. Then you go to cardiology and you're like, oh, this is a whole new world, and everyone there knows everything about cardiology.
Yeah.
You just feel like inadequate, but it's just, it's part of it. We rotate through it. There's a fellowship for it because
yeah, exactly. Yeah,
So.
I mean, as a transitional year, I was in the ED, and so you see how that was a whole learning curve. And then, you see these third-year ED residents that are just, doing these resuscitations and these, innovations and all these other things, and they're really killing it. Doing great patient care in a very stressful environment. And then you get to medicine, and that's a whole different. I mean, it's completely different. I think, and then I did a month, as of vascular surgery. So like I've seen, EM, internal medicine, and a surgical perspective, and they're all three. There obviously is there's overlap, but they're also very, very different. So that was definitely, and then the ICU is honestly, even though it's still medicine, it's a whole other kind of workflow or way of doing things. And so that's been also kind of a learning curve. It's basically like one learning curve after the other. And then I'm sure I haven't done a lot of outpatient like you have, but I'm sure, that's its own learning curve in its sense.
Yeah. And there's a lot to do there too, even from home, you got to answer patients' questions and then just, that's a whole another podcast.
Yeah, for sure.
This podcast is brought to you by DaVinci Academy, and our mission at DaVinci Academy is to provide innovative learning resources for students studying the medical sciences and enables them to learn the fundamental concepts in an easy to follow way, and then learn to apply those concepts to clinical situations that are frequently tested on medical school exams and board exams. We have video courses available on our website for anatomy, histology, and biochemistry currently. We also have outline format textbooks that complement those subjects and are meant to supplement the videos, and those books are available in both paperback and ebook forms. We also have a free clinical case video series called DaVinci Cases, available on our website and our YouTube channel.
So I guess for the med students listening out there, I guess what would you say, I feel like we're far enough into interning at this point. What would you say the biggest difference between being a med student on like medicine or ICU and between being the medical student on the service and being the intern on the service? Like what, like as far as just like what your expected responsibilities, like, you know, because people I'm sure especially the fourth years, like they've got being a med student down on the service, you know, but like what should they expect as like the bigger difference now in your opinion?
Yeah, I think, I mean, you're responsible for things happening. You know, as a med student, you might get to call the consults, depends on, you know, who's there, and you might get to, you know, follow up on things, but in the end of the day, you're not really responsible for anything, which is a great feeling as a med student. You're just there to learn. You get to have a couple of patients, you present, which is great for residents, you know. Present. But yeah, I think it's just that whole level of responsibility. You have to get things done. You have to put in the orders. You have to make sure they get done. You have to call nurses. I think other things are social stuff. So dispo things like, where's the patient going? When are they going? Is there a family member that has questions? Are you able to answer those questions? You know? And I think going in and just feeling like, you know, you just have to do those things. So I think that's the biggest difference. And yeah, as a med student, you go home and you get to maybe study a little bit more. You know, it depends on your schedule. You might have weekends off, but that also all depends on how much responsibility like your med school gives you to the fourth year. So it all differs, but yeah, just getting things done and being responsible for stuff, I think, is the main difference.
Yeah, I would agree with that. I mean, like, I don't think I've ever seen a nurse like page a med student or epic chat a med student. So I think like feeling those questions from, you know, nurses and other people, calling consults. Yeah, it's variable. I remember I did that a little bit of that as a med student. We usually let the med students, if they're comfortable, do it here. But it's still like, I don't know. Again, like usually you don't put orders in as a med student, or you have to have like someone co-sign them. So it's not like, and usually like as a med student, you're not putting in heparin drips, like, you know what I mean? Or like, you know, complex things like that. So yeah, I think it's definitely, I think you hit the nail on the head. Like, I agree. It's just like the level of responsibility, like all these tasks that are talked about in the morning on rounds, like you're responsible for getting those done. Like if those don't get done, then you're going to be in trouble.
Yeah. And I've been very lucky to have like great med students. Like they'll offer to go talk to the family is probably, we usually go do that, but they'll offer like to follow up on things. They'll make sure that things are, you know, if we get a scan or something like that, they'll you know, update me if it's there, if I'm busy or something like that.
Sure.
Yeah, I guess responsibilities for med students also vary based on the med student too. You know, you trust some people more than others, and also depends on how enthusiastic they are. You know, you give more responsibilities to those who really want to do more. So, which I think that's another part about rotating as an intern through different subspecialties. Like, I think this is what helped me in medical school was I always was like, okay, maybe this is something I'll do. You know, even if I was like 99% sure neurology was not going to be my choice, still excited every day. You know, willing to learn, not just like kind of walking around not caring. I think that's important as an intern, and probably important just in life as an attending. And you know, if you're looking for, you know, if you want an administrative role, any kind of that stuff, you want to be excited about most things.
Yeah, and I think it's like, especially from my perspective, you know, I'm only doing this for a year. That just knowing the perspective of different services. I think that's something I try to learn. And then like, obviously from an imaging perspective, like why they're ordering, like on the clinical side of things, like why are they ordering a chest x-ray in this scenario? Like, what are they trying to expect? What will they be expecting from me as a radiologist reading that? Or, you know, when they're referring somebody for a procedure, you know, what are they, you know, what is the end goal here? How does this help the overall patient's care? Things like that. Obviously vascular surgery, there was a lot of overlap with, you know, interventional and endovascular stuff. ICU, you know, obviously as well, like, you know, who's sick, who's not, that type of thing. Yeah, definitely. I haven't done a neurology, but I think knowing from their perspective, like, you know, when's a stroke, when's it not a stroke, like things like that, seizures. I think kind of getting, I think just getting like other services perspectives, just I think even kind of seeing things through their eyes, through the ED's eyes. And so I think, you know, I think it's good to see like both sides of that. Cause I think, you know, everyone kind of talks some smack about everybody else sometimes. And so I think like it's good for ED residents to see the internal medicine side of things. It's good for internal medicine to see the ED side of things as well, because you don't really know it until you like live it. You know what I mean?
Right.
And so I think that's the biggest thing. That's the biggest thing I've tried to gain is just like perspective on everybody through this year. In addition to, because like I'm not going to be dosing like insulin, you know, I'll never do that again after this year, or like things like that. But you know, if I can understand why you guys are trying to like look for certain things in imaging, I think that's where we can provide the most help.
Yeah, and I think one of the things that I learned on subspecialty series, I forget what attending told me this, but you know, if you're cardiology and you get consulted for, you know, sometimes you get consulted for things that are maybe could be sorted out by someone else, or you know, things like that, like for chest pain. And the best thing to do is just, it's easy for you to work up chest pain, you know, for a cardiologist.
Sure.
It is much faster, much easier, and just go do it. You know, even if you feel like it's not a great consult, you just do it because it's easier for you, and then everything is done. There's just better relationships after, you know, you're not pushing things off. And I think that's one of the things that I've learned going through different rotations is just do it.
Yeah. Yeah. I think that's kind of a recurring theme. I think the other thing with, I was going to say, there was one other thing I was going to say with being a med student, and is I think a big adjustment is like when you're a med student, you have a lot of time to read about your patient, and like kind of like that one phase I was talking about where like knowing what's going on with the patient, like you have a lot, like you're only carrying, you know, obviously whatever it is, usually you're carrying less than what an intern would carry.
Yeah.
At least at our institution, that's usually the case. Or actually that's pretty much always the case. And so you have more time to learn about the patient. And I think a big thing to try to work on, and obviously it's a process, is like knowing what the important stuff is to know. Like when you go through the chart with a new admission, like that first run through, like what do you know, you obviously look at the labs, you look at like EKG or, you know, whatever, you look at what they were presenting with. And then, because you just don't have, like when you're getting crushed with admissions and then you're also carrying a bunch of old patients, like you don't have time to like really, you know, spend all that time to like learn about all those patients, you know what I mean? And so I think that's a big like kind of step. And I think the way you do that is a lot of it's just from experience. I don't know if you have any tips and tricks for that, but like, I think like what to look for, because you just have to see something enough times. Like you see someone come in with heart failure, like you know what to look for. You know to look for in the chart, like were they ever hospitalized with heart failure before? You know, what kind of diuretic regimen did they do? What medications have they been on? Like you're not going to like read through some, you know, ED visit where they came in with, you know, bloody stools or whatever. I mean, you'll take a look at it maybe, but you're not going to like, you know, if they were sent home the same day, you know, or whatever. I guess bloody stool is probably not the best example, but maybe like, you know, if they came in like, you know, they were, you know, I don't know, something like they fell or something, like it was like a, you know, musculoskeletal thing, and then they went home the next day, like, or the same day, like that isn't going to be as relevant to, you know, someone who's coming in with, you know, with their current problem of heart failure exacerbation.
Yeah. So I think it just takes practice. It just,
yeah.
Yeah, you just have to just try to do better every time.
Yeah, exactly.
And I think on services, off-service rotations, you just have to figure out what's important for them. So for maybe if they're being admitted to the medicine service, or let's say nephrology, you might not look at an echo that they had last year, or try to look through the records for their any
Right.
kind of ischemic workup that they've had. But if you're on cardiology, like those are the things you start looking for.
Absolutely.
And so you just have to know what's relevant for you at that moment in time. And I think the first things you do is when you look at well, even when you're getting the call for the consult, let's say the attending or whoever's handing out the admissions, you just want to say, are they stable, and then look up their vital signs. And then kind of, do you need to go down right away before you're really reading anything, or do you have a few minutes to kind of catch up on the chart, figure out what's going on, what they've gotten so far, what's the workup been? So I think that's one of the most important things to start with as early as you can, is figuring out how fast you need to get down there.
Knowing like, is this someone I shouldn't, because sometimes like you get the sense like you really shouldn't spend any time looking through the chart if they're not stable, or you get the sense that things are going to go south quick. Now sometimes you have a senior that can, they'll go down and see them while you're kind of gathering some more information, but in some scenarios it's it's kind of best if everybody just goes down, depending on what's going on.
Right.
So I think, because that's something I've noticed, like, the medicines, when they try to push themselves and pick up more patients, they'll ask me sometimes, they'll be like, how do you carry like all these, like on medicine wards, like, the medicine will carry like, 2 or 3 patients and we're carrying like 8 or 9. And they'll say like, how do you, so that's a big difference between carrying 2 and 3 and 8 or 9. So I think it's just knowing what to selectively look for, and keep on track. And I mean, obviously if you have time at the end of the day, then, I'll have times where that happens, where you'll go, I want to kind of look through more on this patient, like, what regimen were they on for some type of, problem they have? Well, what does their latest primary care notes say? Like things like that. And you can take time at the end of the day to go through that to gain a better understanding, but in the moment, you kind of have to be selective. And like you said, I think that just comes with practice and experience. So
awesome. Agreed.
Let's see here. Let me look at some of our questions here. I feel like we've answered some of these already. I guess this will probably be a broken record, but I guess, the huge learning curve, and like going through all these learning curves, I guess, I guess we're trying to just to provide, I guess, a little more specifics for people. I guess, is there anything you did to like kind of manage this learning curve that we constantly are on?
I don't think there's anything like a secret.
Yeah.
It's honestly, I think you're going to have bad days. You're going to come home. You feel like you did a, terrible job. Your presentations were terrible or things like that. But you just get up the next day, you try again. You just have to get used to that. And sometimes you'll come home and you're like, wow, I'm a superstar. Like, I know everything. And then the next day you realize you don't know as much as you thought you did. And I think just getting used to that and not being too hard on yourself, and then just knowing your like limitations and things like that. But more specifics, like, again, you pick this up as you go, but for admissions, like, you always want to see if the patient was discharged like last week. And then you can just read that discharge summary and kind of know exactly what the patient's story is. And again, like vital signs. One of our attendings, I'm going to butcher this, but he's got like, I think 3 rules. It's like vital signs are vital for a reason, and then I forget one of them, but the other one is all bleeding stops eventually. Hopefully you never have to get to that point. But yeah, like knowing the vital signs, that's like the important thing. You want to, what are their maps? What do their initial labs look like? How sick are they? What have they gotten in the ED? And again, you pick that up as you go. And the great thing about, medicine training is that you're never alone. There's a senior resident, there's attendings, there's, APPs, NPs, whoever's on your team, they're always there to also help. And I think that's great as a learner. You always want to know that someone else is there to answer your questions, or because at some point, it depends on where you practice, there might not be someone to answer that question. But at this time, like, the point is of us learning how to manage this stuff. So it's good to have a team.
I think definitely. I think that's a big thing, is you said there, 2 things, is like knowing your limitations and knowing when to ask like for help, or like, I mean, that first month, like, you gotta, you just don't know this stuff. And like anyone who expects you to know that stuff is just a jerk. I mean, like, if they expect you to know how to like put all these orders in and all that, that's just like unreasonable. So I think, knowing your limitations, and then like, I think just leaning on your senior residents, or if you're with a fellow or somebody, or, you know, or if you're by yourself with the attending, like, I think, you know, even if I think not being afraid of looking stupid, I think you just have to let that go out the window. I mean, I think, you know, you just gotta, you know, if you don't know something, you don't know it, or you don't know how to do something, you don't know how to do it. Like, you know, and no one should, especially those first few months, no one should fault you for that. There's still things I don't know how to do.
Yeah.
You know, in the ICU, I was like, my first week in the ICU, I was asking a lot of questions of my senior resident, just because I didn't know, like, is this appropriate in the ICU? Like, you know, do we do this? Like, you know, so I think leaning on your senior a lot, and that's true, I think, no matter what specialty you're in, you know, surgery, medicine, you know, EM, things like that. So I think, you know, not being afraid to ask for help, and knowing, you know, if you're in, I remember like the first month of wards, I had a patient that was visibly crashing. Like, you know, they were going into cardiogenic shock as I was examining them. Like, their extremities were turning cold. They were desatting, their blood pressure was dropping. My senior resident was off. And so I called, it was in the ED. So I was able to grab one of the ED attendings that I knew there, but I called my attending, and she was glad. She's like, I'm glad you called. And so, because like, you can't, especially in the first couple of months of internship, you can't be expected to know how to deal with that. You know what I mean?
Yeah.
And so like, that's why you call, you know, that's why there's these, you know, that's why it's not just an intern by yourself. Like, you know, you've got people to rely on. So
yeah, and the attendings are on teach service because they want to teach.
right. Yeah.
So I have yet to have an experience where I asked the attending a question or called them uh, you know, because I was worried or I didn't know something, and there's never been a time where they're like, "Why did you call me?" That's just, no, that's not why they're there. They're there to teach you. So they're gonna answer your questions or explain, oh, you know, oh no, it's totally fine. You don't have to worry about that. Or they'll be like, oh, thanks for calling me. Let me come see the patient.
Yeah.
I think the other thing is, and first month is probably impossible to do this, but as you go through the first year, is finding like appropriate resources to learn about the specialties. So for example, like medicine, like as an intern, you'll get access to MixApp or whatever resource your program offers. I think there are a couple of different ones, but also like finding your go-to resource. So like everyone uses UpToDate. That's great. UpToDate is what I use for drugs all the time, like dosing,
sure. Yeah, me too.
renal adjustments, and or even like reviewing the mechanism or pharmacology, like how long is it going to take for this drug to kick in? And
right.
it's like, oh, I'm going to give this orally. Oh, it's going to take an hour for it to work. Okay, maybe. And then, but what I started using was Dynamed, which I think was like really emphasized at Toledo, but I never used it. I'm
Sure.
pretty sure we had access to it. And I was like, oh, no, UpToDate's the best. And then I started looking at Dynamed this year, and it's perfect. It's very concise.
Yeah.
Bulletin points, and then they go into detail if you scroll farther down on each page. But you get to figure out like dosing management, workup, things like that. And for critical care, EM Crit is there's a website, a podcast,
Oh yeah.
and they have that online book. So just finding those resources quick, having a reference guide. And the other thing is, one of my attendings first month told me, like, if you're interested in academic medicine, use I think it's called Evernote. Have you used Evernote?
I've heard of it. I don't think I haven't used it.
So I started using it more often now, but it's basically a note-taking website or app, and you can pay for it or you can use it for free, depends on how many devices you want to use it on. But it organizes your notes in notebook like format, and then it's searchable, and you can have it on your phone, your laptop. So what I started doing is either making my own tables or just copying and pasting like dosing for sedation and like side effects or whatever it is. And then you can quickly look it up on your phone anytime.
Yeah.
Because you have all these great resources, like you have 20 different ways you learn about hyponatremia, and maybe each resource has like one thing you like the most.
Sure.
Then you have to go back and look at those resources, find that video or find that segment. But I started just copying and pasting each individual thing into this Evernote thing, and it's been really helpful.
Yeah, I think that's a better way, because I remember on ICU the first week, I didn't know any of these drugs like for sedation. And so I made
Yeah.
I actually made note cards like the old fashioned way and kept them in my like white coat, and like pressers and stuff and like what the side effects are. But like, yeah, if you have like an electronic resource where you can keep that stuff handy and like, and I think the searchable thing, that's really nice.
Yeah. And
So
just
yeah.
type in whatever it is. And I don't get paid by Evernote. So
Yeah, we don't have a financial stake in that. No, I think that's great. Yeah, I think asking your like upper level residents, it's like, oh, obviously
yeah.
I think that one an attending told you too, but I think asking them again for help, like what are good resources. And I think one thing I just want to mention also is, you may be thinking, hearing us say this, oh, ask for help, ask thing, you may be thinking, well, what if I'm dealing with a jerk? Like, what if my senior resident's a jerk? What if my fellow's a jerk or my attending? And I think in those scenarios, I remember someone gave me really good advice, like during med school and like on how to deal with people like that is you can't cater to everybody's personal, defects or whatever. You can't cater to these people's issues. A lot of times it's not you, that's how they treat everybody. It's like personal issues they're dealing with or things like that. And I think you just ask for help, and if they yell at you or they give you shit about it, I think you take it, because the problem is if you don't ask for help and you screw it up, they're gonna be like, well, why didn't you ask me? So it's like those situations are terrible, because especially as an intern, it's just a no-win. You're probably gonna get yelled at either way. And unfortunately, I haven't had to deal with a lot of these situations this year, but there's been certain instances, and I think that's usually the way I handle it. I think, unfortunately, you got to develop thick skin as an intern, because you're going to look stupid. I don't care if you got a 270 on step one, you were a Rhodes Scholar and went to Harvard, like you're going to look like an absolute moron at times. It's just the way it is. And it's not because you're stupid. It's just, you don't know. And I think, just because you don't know things doesn't mean you're an idiot or you're stupid. You just don't know. And so I think you just take it and, you move on, and you just count the days so you get off that rotation, or until that person rotates off, and you keep moving. And I think, it's not unique to medicine, and not in other jobs you'd have to deal with. At least in medicine residency, you can rotate off, service.
Yeah.
Like these people in regular jobs, like sometimes that's their life every day until they quit that job or that person leaves, is they have to deal with somebody like that. So
Yeah.
I think even in those scenarios, yeah, go ahead.
Oh, I was going to say, and everyone's going to have their own preference. So I've been very fortunate. I haven't had any bad experiences yet, but and I'm also an optimist, so maybe but what every attending is going to have their own way that they want a presentation done. They'll want, just give me the quick spiel, or attendings want like start from the beginning. It's the first time I'm running the patient, so you have to tell the whole story. So you just have to adjust those things to everyone's preference, and that's just part of it too. You just have to learn how to do that, and just roll with it, just because that's how it is. And some people have that preference, and then you'll have your own preferences once you're an attending, and people will have to adjust to you. So it's just like
I think that's a very common theme across all. I see it I saw it in every specialty I rotated on. I've done some radiology. Even with that, there's certain ways, like in radiology, you're dictating reports for imaging. There's certain ways people want, different attendings want different ways for the report or what's reported. In IR procedures, there's different, obviously it's like surgery. There's different ways of doing things. Obviously in surgery, there's, a lot of different preferences attendings have for things in the OR, and ICU. Attendings have different preferences or how things are done. So yeah, I think you do your best with that. And just like you say, you realize that, it is, again, you like that one person said to me, you do your best, but you can't kill yourself catering to every person's like preferences or things, or their own, preferences, I guess. I guess kind of wrap things up. What kind of just more about you, like I know we talk a lot about this. I think you're interested in academic medicine. Like what kind of academic pursuits are you working on right now, like outside of your clinical work? And I guess also like, how do you manage that? Because I imagine there's a lot of listeners out there that like, they're doing things outside. They're trying to find, it's always that challenge of finding that balance.
Yeah. So for internal medicine, I think most programs, I don't know if you get a research month your first year. We fortunately do. So, I'm trying to do research, help me. I'm not sure exactly what fellowship I want to do yet, but if you want to stay in academic medicine, whether it be in, hospital, internal medicine, general medicine, or subspecialty, you probably have to do some kind of research. Um, but yeah, so we're lucky enough to where we have a month of just dedicated time to work on a project. And then, you find time. Sometimes you'll have rotations where you're not working so hard. And even if you're there, you have some spare time, like especially on nights, nights, sometimes you will have a night where you have only a few admissions, depends on what you're on. So you squeeze some things in there. And it's hard, just know your limits. If you need a break, you need time off, don't work on research, go enjoy life, because you just worked, whatever, 80 hours that week.
Right.
You can't feel like you have to go home, study or do research, spend time with family. And I think most of medicine is moving towards, understanding that, people just get burned out. And I've felt like our program has done a good job. I haven't felt like burned out this year, which again, I'm pretty optimistic about things. So not to say that, if you do feel that way, that's important to take a break. And all programs have, most programs have a way for you to talk to somebody as well, if you're feeling that way. And I think if you're doing research and you tell your PI that, you can't do this right now, you need some time, they all understand. So finding time is, if there's dedicated time, that's great. If there's easy rotation, do it then. And there's also, next year and the year after, you have all this time to do those projects. And then finding things to do outside of work. My fiance was kind enough to build me a gym for my birthday in my garage.
So nice.
I don't have to drive anywhere to go work out. I can, on my day off, I just go into my garage, work out. And so you can kind of cater things to yourself, like make it more accessible for you to do things that you want to do.
I think that's a question I have for you was, you've been really into, every time I talk to you, you're, really into fitness and staying, which is awesome. I'm trying to follow suit here. I actually bought a stationary bike for my apartment. So same kind of thing. I have no excuse to not do some type of exercise. Cause I think as doctors we're like, oh, I don't have time for that. Or like, I'm too burnt out, or, it was too tough of a day, or I don't know. So like, I think probably a lot of people are curious, like, how do you work out in the, like, I know some people get up really early and try to do it before, but sometimes that's just hard because you'd have to get up crazy early, or like some people do it after, but then I don't know, sometimes people argue, oh, I'm too tired. I guess how do you, because you're a pretty fit guy, you stay in shape. Like, how do you do that?
I set an alarm every morning for like 4 a.m. and I'm like, I'm gonna get up and I'm gonna work out. And then that snooze button gets hit like 20 times. I just get up to go shower and go straight to work. I think, some months it's harder. Some months I don't work out. Maybe once, on ICU right now, it's been 2 weeks and I worked out maybe twice or 3 times. And you just have to adjust to whatever your schedule is. But other times you come home, sometimes you just do it. That's the first thing you do. Like, especially after nights, night shifts can be, we're lucky we don't have like a 28 or whatever, 24-hour call, or we usually just have a night shift, or we work 12 hours or 14 hours, whatever, overnight. And then, so I just come home after night shift and I just work out right away. So I just can't not, and I just go to bed then. Because if I tell myself, I'll eat, I'll go to sleep, I'll wake up before my shift and I'll work out, that doesn't happen. I'll sleep till 4:30 and then I get up and run to work. So, and I think, health is important, for us to, if you work out, you'll probably have more energy and you just build those habits. But again, you just can't be too hard on yourself. You can't, if you can't, just, if you need rest, you want to watch TV, just want to read, go outside for a walk, like do those things, find ways that you feel more relaxed, that help you take your mind off things. So each person has their own thing. Just for me, it's this. For other people, it might be reading a book or TikTok, whatever it is.
No, I think it's good. I think it sounds like, again, the recurring thing, you just got to do it. Like it's, and you just got to make it a priority. That's what I've learned. I mean, sometimes the best part of the workout is just when it's over, but at least you did it, and I think, you're always going to be like, being too tired, or, I think you gotta, I think also trying to remember that it's like good for your health
Yeah.
as much as that can be, like, oh, yeah, I don't care. But, I think it's just good habits. I think you make a really good point. Sometimes you just don't have the time. I mean, it's not, you can't beat yourself up. I think it's just being consistent. Like you said, like you've done, a couple times, but at least you did it. Like, at least the next time you do it, it's not like, oh, it's been 4 weeks since I worked out. Like, it's only been like a week or a few days, or, that kind of thing.
Right. And usually I listen to like a TED talk to like motivate me to go do something, and that lasts a day or two.
Yeah.
And then you gotta, but yeah, I think again, intern year is hard. You just have to make sure that you're resting enough, finding a balance. So just even for those things like working out or doing things outside of work, like don't be too hard on yourself if you don't get to do them, if you just need sleep or whatever it is.
Like if you have a day off, I think, you don't need to always feel like, especially when you're on a rotation, you only have one day off a week. Like sometimes, I mean, if you got really worked hard that week, like there's nothing wrong with just chilling out. I got this friend here who he claims he's just like, yeah, man, I just do nothing. And I was like, yeah. He's like, I get Q2 turns. I was like, a bedside delivery, Uber Eats. Like, I mean, I was joking with him on that. And, and like, there's nothing wrong with that. Like, you just chill. Like, he works really hard and he's a really good resident, but he just chills out. Like, and he goes to the gym and works out, but otherwise he's just chilling. And I mean, sometimes you just need that. Like, you can't, again, like you say, you can't be too hard on yourself.
Yeah. And, if the gym's not your thing too, that's not how you relax. If that's stressful, and just find something like play, some people don't want to work out, but they'll play a sport of some sort, like tennis or hikes. I'm lucky enough to live in Arizona where go on a hike most of the time, without like, it being too hot, which is getting to at that point. But those things, and do it with friends. And I think, those are the important things. Balance is important. We have a very very balanced program. So I feel like this year has not been as hard as it maybe could have been.
Nice.
So, and if you have a significant other, if you get to pick working out, or do you get to hang out with them? And sometimes you just, you have to hang out.
That's right.
That's not, and making it sound like I don't want to hang out with my fiance. No, but you just prioritize.
Right.
You go to dinner or spend time together, and you work out another time, and find things to do together that you both enjoy. And I guess this year has been even harder to like hang out with your classmates as well. You don't get to go to a restaurant or some event together because of COVID, but hopefully that's going to turn around and people can spend time together. Because I think getting close and getting to know your class is also important, because you're going to spend most of the time with them.
Yeah, and, definitely. And they know what you're going through. Like you can,
right. They work with the same attendings. They work, same shifts, same specialties, and sometimes you get a vent. And
exactly. Yeah.
People that went through it is the best people to vent to. So
absolutely. Well, I think that's all the questions I have, and I guess just in the interest of time, I think we'll wrap things up. But Nikita, it was awesome to talk to you, man. I'm glad you're doing well, and thanks again for taking time out of your busy schedule to come on here. I think we gave the listeners some good pearls. But yeah, thanks again for coming on, man.
No, of course. Thanks for having me, and I'm happy to do it again. Can't believe it's been almost 5 years since anatomy.
I know, but it's crazy, man. It's crazy.
It's gonna, man. It's good to see you. We'll catch up again soon, and congrats on all the cool things you're doing. You're doing great, man.
Thank you.
Thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. More episodes are available on our website at dviacademy.com, our YouTube channel. They're also available on Spotify and Apple Podcasts. Also on our website, you can find our video courses for anatomy, biochemistry, and histology, and they're available as month-to-month packages. They're also available as a combo package where you can get all 3 courses in one. Our website also has a store where you can find our outline format textbooks for anatomy, biochemistry, and histology. All textbooks are available in paperback version and as eBooks as well. These textbooks complement our video courses and provide a nice addition to the learning experience of allowing you to focus on the learning and not having to write anything down. On our website, we also provide a free clinical cases video series called DaVinci Cases. DaVinci Cases aims to help you learn how to answer USMLE questions and apply concepts that you learn in our courses to answering those questions. Our cases cover a variety of topics and organ systems, and they're updated frequently with new cases. And then lastly, on our website, you can find our blog, which has interesting articles that cover medical history, important figures in medicine, and innovations in medicine. Again, thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. Please be sure to tune in for our next episode.